My name is Sinead Murphy. I am an Advanced Nurse Practitioner, formerly of Epilepsy Ireland and looking after the pregnant women around the country, but the new Advanced Nurse Practitioner for St. Vincent's Hospital. So I am going to go through just some information with regard to women with epilepsy and taking into consideration pre-pregnancy, pregnancy and postpartum care. And I'm really thankful, first of all, to Epilepsy Ireland for organising this event, which goes without saying is amazing to see so many people turning up, but also as well to Pauline, who is a fountain of knowledge and I'm sure will dispel many myths. So I suppose I wanted to start talking about bad news, first of all, because we all know that where there is epilepsy, sometimes there is some bad news. And when I went to research this talk, I wanted to point out that even though there's bad news, Ireland is way ahead, I suppose, in looking after women with epilepsy and in the guidelines that we've produced. And what's the evidence around this? Well, looking at the internet, valproate is still widely prescribed. And this was an article in a paper 11 months ago calling for an advisory committee on medicines to tighten prescribing requirements for sodium valproate. So I suppose we're way ahead of that, but I will go into that in a bit more detail. So in 2018, there was an alert issued around the prescribing of valproate. Why was that the case? Well, we found that there was a 7 to 10% of a child presenting with a major malformation in around valproate. But what was coming to light, I suppose, more and more was the chance of a neurodevelopmental delay. And so in women who took valproate during pregnancy. And so there was this document issued, which is the annual valproate acknowledgement form, which said that any woman who continued to take valproate within her childbearing age should be reviewed by an epilepsy specialist annually, and all the updated information should be given to her. And then most recently in 2023, there was the same pregnancy prevention program came into play with regard to topiramate. So I suppose if you take anything from this tonight, it is really, really important that new information emerges all the time. In fact, we've new information with regard to men taking valproate. So it's really important that you contact your epilepsy specialist, be that your nurse or your doctor, or even your GP, to talk about planning a pregnancy. And it would be really, really important that you do this at least 18 months before conception takes place. I wouldn't be doing my job properly if I didn't mention sudden unexpected death in epilepsy. And unfortunately, the risk of dying increases in pregnancy than it does outside pregnancy. And that risk increases up to 1 year postpartum. So I looked at the most recent Embrace report, and out of the 14 deaths, 8 of those women were taking lamotrigine, 6 of the women were taking levetiracetam, 2 taking both of those drugs together, and the other drugs were topiramate, carbamazepine, and phenobarbital. So why do the deaths? I want to reassure you, first of all, in saying that it's a very, very, very rare thing that this happens. Our last death that we are aware of is in 2019. So that's 6 years ago now. And when you look at the figures in the UK, they say that 1 in 1,000 women with active epilepsy die in pregnancy in the first year postpartum. And when you look at the figures in the Republic of Ireland, we do only have about 400 births a year with women with active epilepsy. So I do want to reassure you that the risk is really, 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 really small. But in order to negate that risk further, we need to educate you on how you can keep yourself safe. And what the Embrace report says time and time again is medication adherence is really, really important. So when you do confirm a pregnancy, you never, ever, ever stop taking your medicines without medical advice. You need to make sure that you are attending a specialist access a service. So it is really important that you do attend a service that has access to both good obstetric care, but also good neurology care, and that both services talk between each other. And it is really important then that your specialists in this regard take advantage of any training resources that are around this area. So I looked about folic acids as supplementation first of all, and I looked at this study which highlighted that there's a 1.8 possible spend on women with epilepsy throughout the world. And they say that this 1.8 million is 3 times higher than the global spending caring for people with epilepsy in the world. But what do they say about folic acid supplementation? Well, they say that it is projected to be the most effective intervention in caring for women with epilepsy, because it says it can have a 9.1% reduction in major congenital malformations, a 14.9% reduction in the autism spectrum disorder, and a 10.8% reduction in offspring-related economic burden annually. So ultimately, what this paper is saying, that we need to encourage folic acid supplementation. We need to make sure that women are optimized in their dose of anti-seizure medicine. We need to make sure that women are counseled in a pre-pregnancy state, and that would, as I say, begin really with when the woman is diagnosed, but most especially in around 18 months prior to conception. We need to make sure that there's improved access to specialist care for these women, and we need to make sure that there's early pregnancy diagnosis and monitoring. When we look at prescribing patterns for higher dose folic acid in pregnant women, what we can see is that those rates of prescribing vary depending on what country you're in, and considering Sweden, Norway and Denmark have more or less the same healthcare system that's used in those 3 countries, there is a concern as to why the prescribing rates for folic acid differ between those countries. In this study, they looked at just over 2 million women. 8,000 of those were pregnancies in women with anti-seizure medicine treated epilepsy. And what they found was that only over half were on the higher dose of folic acid. And what they said was that 42% of women who used the higher dose of folic acid did not start in preconception supplementation. And when you look at the previous paper and you look at how much folic acid can help in the development of the baby, it is really, really important that we do encourage all women with epilepsy to take some folic acid. And why is there such discrepancy amongst women who take different doses of folic acid in pregnancy? Well, it's probably owing to this paper in particular that was produced out of the Scandinavian countries. When they looked at a database of women with epilepsy on anti-seizure medicines, they found that in women who took a dose of folic acid in 1 milligram or more had a 2-fold increase in childhood cancer risk. So this has been taken to the experts, I suppose, if you like, around Ireland. And unfortunately, there is no consensus on what dose folic acid is best for women in preconceptual stage. But what we have discussed, and it's a local agreement, is that women with epilepsy who are planning babies should be commenced on 5 milligrams once a day up until week 15 of pregnancy. And once week 15 is confirmed, then the woman can drop down to the 0.8 milligrams of folic acid. Now, of course, in Ireland, 5 milligrams is prescribed, so it has to be prescribed by a clinician. The 0.8 milligrams is not available, so that's 2 of the over-the-counter folic acids. But in questioning women in around folic acid, what we do realize is that women also take Pregnacare as well throughout their pregnancy, especially when they confirm their pregnancy. And that also has a 0.4 milligram. So, in most cases, you actually have mums taking anywhere between 5.4 milligrams of folic acid and 1.2 milligrams of folic acid. But just to reassure you, women who have had bariatric surgery or women who have diabetes have been taking folic acid 5 milligrams for a very, very long time. And this study has not been replicated. The only thing about this study is that it had a huge amount of participants that made it, I suppose, a more valid study. But again, just to reiterate, the study has not been replicated, and we would advise that all women of childbearing potential are on 5 milligrams of folic acid once a day for the first 3 months prior to conception, for the first 15 weeks of pregnancy, and then we do drop it down to the 0.8 because we do know that folic acid helps the baby's brain development throughout the pregnancy. So you will often hear quoted that women with epilepsy are at higher risk and have complicated pregnancies. It's certainly not up to me as an epilepsy nurse specialist or up to a neurologist or an obstetrician to tell that woman that she cannot, irrespective of how bad her epilepsy it is not up to us to tell women whether they can go ahead with their pregnancies or not. And as I've said, the risk is quite small, but it is an ideal time for us to address the possible outcomes that can happen and how we aim to get the woman in the best possible health before she becomes pregnant. So what does that mean? What does that look like? Well, if somebody comes and talks to us at least 18 months prior to conception, it gives us a chance to highlight what is the safest option for that woman in her pregnancy. So it may mean switching to one of the more researched anti-seizure medicines, or it may mean staying on the medicine that she's on that's maybe not as researched, because irrespective of the medicine, we know that the seizures cause the greatest harm with regard to pregnancy and epilepsy and seizures. So in this paper, they looked at what were the reproductive and fetal outcomes in women with epilepsy. And what they found was, with regards to maternal outcomes, compared to women without epilepsy, pregnant women with epilepsy had a significant higher adjusted odds of cesarean section, preeclampsia, eclampsia, gestational hypertension, so high blood pressure, induction of labor, and gestational diabetes and postpartum hemorrhage. I suppose I want to caveat that by saying I have worked extensively in the maternity hospitals, and maybe initially, yes, before I started there, which was a very long time ago, there was a lack of knowledge to do with epilepsy. And so, sometimes when a woman had a history of active epilepsy, it might have been thought that the best idea was to go ahead with a planned cesarean section or induction of labor. That certainly isn't the case anymore. And I think as women with epilepsy, you have to educate yourself, but you also have to advocate for yourself as well. So you need to make sure that you're making the right decision for the right reasons in conjunction with your obstetrician. Some of these cesarean sections may also have been the case that the baby was breech, which is, even if you don't have epilepsy, you will have a cesarean section if this is your first baby. When they looked at fetal and neonatal outcomes, they showed that the pregnant women, the babies who were born to pregnant women with epilepsy, were smaller for gestational age, had a lighter weight, a lower birth weight, a higher instance of congenital malformations and fetal distress. But also, I want to go back and say that, drugs have improved over time. We know that lamictal levetiracetam and trileptal monotherapy, so that means where you take one drug on its own, are the safest drugs for women with epilepsy. But these drugs don't suit everybody. And like I said, the seizures far outweigh the difficulties, and particularly the generalized tonic-clonic seizures where you fall down and stiffen and shake. They are known to cause, maybe small for gestational age, low birth weight with regard to the pregnant woman with epilepsy. So again, it's not all about the medicines. And again, we did see operative vaginal delivery, and there was no significant difference with an operative vaginal delivery. So we mean forceps and vacuum by that, and newborn mortality. And then just another little bit of science, and very briefly, this is the MONAD study, or known as the Maternal Outcomes and Neurodevelopment Effects of Anti-Seizure Drugs. And basically, they looked at children up to the age of 6 years of age, where they looked at whether the taking of lamotrigine and levetiracetam had any significant differences in compared to children who weren't exposed to these medicines. And I suppose the paper is very positive in saying that there was no differences between any of the verbal abilities comparable to the controls. There was no overall negative impact on the verbal index score from the anti-seizure blood medicine levels that were withdrawn in the third trimester. Again, this paper highlighted the benefit of folic acid and early use of folic acid in pregnancy, and there were other significant influencing factors such as maternal IQ and maternal education level as well. So just to move on to the practical part, and I know that some of you have been sending in questions, and for any questions I don't get to now, I will of course be here at the end that I will answer your questions together with Epilepsy Ireland as well. So what does extra antenatal support mean, and what does it look like? Well, there is a report that says that women with epilepsy are more vulnerable during their pregnancy and should be considered into a high risk group. So what does that mean, and what in real sense, what does it look like? Well, there is the HSE guideline in place on the HSE website, which invariably does need to be updated, but not significantly. And later on this year, for anybody who's interested, or early next year, the Royal College of Obstetricians and Gynecologists will also publish in the UK the green top guidance, but that's there at the moment. Now, there are some subtle differences. But what do the Irish guidelines say? Well, the Irish guidelines say that the person with epilepsy should be managed in an obstetric unit that is capable of looking after the woman with epilepsy. So they have to have a high risk clinic, basically. They should be seen a minimum of 3 times during their pregnancy. They should have their anti-seizure levels monitored. Now, unfortunately, again, there's a lot of discrepancy around guidance around this. But if you look at maybe women getting mixed messages and stopping their anti-seizure medicines, that's a reason to do anti-seizure drug levels. If you look at the papers that examine the levels of medicine during pregnancy, like I was looking at one today that said lacosamide, Vimpat can drop up to 40% in the 3rd trimester. So in my personal opinion, irrespective of anybody else, is that you should have your levels taken pre-pregnancy. I want to say at the same time every time. So when you get pregnant, you make sure the levels are done at the same time. But are you closely monitored? Are you managed any differently? My opinion is the only difference is you have a lot more obstetric visits and seen by your epilepsy specialist 3 times during your pregnancy than if you had no other chronic condition. Now, bearing in mind, again, this is to do with, could be diabetes, could be asthma, any of those things. So you are closely monitored. So yes, there is extra antenatal support. What are the chances of my child developing epilepsy? Well, this is multifactorial, and I know that genetics are playing a more frequent role now, and especially what the neurology centres are doing are looking at the genetics of epilepsy. So we are going to get to understand it a bit more. But it's not just as easy as saying, what are the chances of my child developing epilepsy? Because it actually is multifactorial. So it depends on what is your epilepsy type, what is your, family risk. Have you family members affected by the epilepsy type? What's your seizure frequency? Is it the mom or is it the dad have epilepsy, or do both parents have epilepsy? And some papers would say it also has something to do with prenatal exposure to certain anti-seizure medicines. Why is that? Well, say if you were on something like Valpert or topiramate, where your child might be, or zonisamide might be smaller or need to be born earlier, well, then there's a risk of epilepsy in that regard if the brain isn't fully developed when the child is born. So I would say to you, if you have a concern about this, the risk in general is very, very small, but you need to discuss with your neurologist who understands your type of epilepsy. Somebody asked the question about what is the psychological supports available to women with epilepsy who are pregnant. Well, it goes without saying that Epilepsy Ireland, with their community resource offices around the Republic of Ireland, are an amazing organisation. And while they don't have a psychological service per se, they are an excellent advocacy and listening service. So they can definitely give you the correct information at the time and give you that support that you need in that regard. It's really important, if you're feeling vulnerable, that you contact your neurology service and you let them know. And certainly historically in the obstetric service, they have access to neuropsychologists, neuropsychiatrists, midwives with mental health expertise. So it's really, really important that at this stage you do engage with your obstetric service and you engage early. And primary care as well. I know that there are many services around the country that provide a voluntary service in counselling. So it'd be really important that you contact your GP and you find out what is available in your local community. And I also want to advocate, self-advocacy is amazing, because we prefer if people come to us and say, listen, I'm really struggling at the moment, and we will try and signpost them or get them the help they need. But if you don't tell us, we don't know. So one of the questions that came in earlier on is, are there any mothers in Ireland with active epilepsy? So at a rough estimate, every year we have approximately 400 women who deliver in Ireland with active epilepsy. What does active epilepsy mean? It means where you've had a seizure in the year preceding your pregnancy. But there are many women that might have been seizure free that may end up having a seizure in pregnancy. So when you meet women in general, and even those who've been seizure free for a very long time, the rule of thumb is a third get better, a third stay the same, and a third get worse. So yes, I have seen many cases where women have horrendous epilepsy and they get pregnant, and their epilepsy certainly goes into remission for those 9 months of their pregnancy. But it is, again, really, really important that you manage your epilepsy in conjunction with your obstetrician and your neurology team. So as I said earlier on, it is not up to us to decide whether having children is an option for you or not. It is a decision that needs to be made by you, for you. But you can, of course, include your neurology service, the National Maternity Hospital in Dublin, the Rotunda Hospital in Dublin, and the Coombe Hospital in Dublin all operate a pre-pregnancy service. So it is a free service. You can live anywhere in the country. They'll probably kill me. But, you can get your GP to refer you into maternal medicine for an assessment, but they won't necessarily look at your epilepsy. They might look at your epilepsy medicine and they might advise you, but they will look at you from an obstetric point of view, and they will give you the best possible advice at the time. There is also the option of attending your GP and discussing it with your GP as well. So, as I've said, the gold standard for going into pregnancy is on one drug where possible, and that one drug means an anti-seizure medicine. So later on this month, there's going to be a launch of what's called the EpiKnow project. And that EpiKnow project looked at the information required. What information do women with epilepsy want? And with the EpiKnow project will come a suite of education tools that will also highlight the safest anti-seizure medicine for pregnancy. So in general terms, when you look at the likes of Lamictal, as I've said, lamotrigine, levetiracetam, Keppra, and oxcarbazepine trileptal. So the latest paper from the European Pregnancy Register would tell us that they are the 3 safest anti-seizure medicine, with trileptal actually jumping levetiracetam for the risk of major malformations in pregnancy. So what does major malformation mean? It means a malformation that requires a surgical correction. So that's what's So if you look at 100 women out there in the street, they have a risk of having a baby with something wrong with it, at 2 to 3%. These are women with no chronic illness, on no medicine. So 100 women walking through the doors of any obstetric unit has the risk of having a baby with something wrong with it at about 2 to 3%. And those three medicines that I mentioned carry the same major malformation risk. So there's no additional risk with those three medicines. Of course, the rest of the medicines, not including valproate and topiramate, because ideally we wouldn't want women on those drugs going into pregnancy. But of course, sometimes they can be the safest drug for that woman. And that needs to be discussed well in advance of planning any pregnancy. But with regard to the other medicines, unfortunately, we just don't have enough information to guarantee what the major malformation rate looks like. We just don't have enough information. With regard to a seizure freedom, we would hope that a woman is 12 months seizure free prior to going into pregnancy, and that she would be on her folic acid 5 milligrams. But I have many, many women who have not gone into pregnancy seizure free and have done very well throughout their pregnancy. So parental care, I suppose the scariest fact, if you like, is that the risk of sudden unexpected death in epilepsy is increased for up to 1 year postpartum. Why is this the case? Well, we think it's something to do with the hemodilution of pregnancy, so your body returning to the pre-pregnancy state. But it may be that this woman is just busy and is forgetting to take her anti-seizure medicines. There are many factors that maybe we don't know them all. But what we do know is the risk can be mitigated and we can help reduce the risk. And as I said, the rate is really, really small. So we need to look at common sense. We need to tell the woman, if she's awake 22 out of 24 hours or 20 hours out of the 24 hours, this isn't necessarily good for this woman. And maybe we need to look at why there's long periods of sleep deprivation. We need to tell her not to take any risks and no baths when she's in the house by herself. And if she's feeling unwell, to make sure and tell somebody. There are alarms available. So Epilepsy Ireland are mindful of information on all the types of alarms available. So, if there's a frequent seizure pattern, it may be advisable to invest in these alarms. A patient recently told me about an app called MediSafe that you can cue your medicines into the app, and it will send you 3 reminders at each time to remind you to take your medicine. And if you don't take it, it will start to ring your next of kin to remind them to remind you to take your medicine. Sleep is really, really, really important. So the general rule is 6 hours of unbroken sleep. So, you may have to ask your partner to take over feeding the baby later in the evening so you can go to bed that little bit earlier. But it is really good advice to ask for any help that you can get during this time, and particularly when the baby's very small. So I suppose I just did 2 case studies at the end. One is a 30-year-old female. She has query localization related epilepsy.
Excuse me, Sinead,
Yeah.
can I come in there? We have time maybe for one quick case study, if that's okay. Thank you so much.
Thank you. I'll tell you, I'll be very quick. But the first one, basically, I just want to highlight is because this woman decided to discontinue her anti-seizure medicines. And while I'm not saying that is the best course of action, we need to respect patient autonomy, but once they have all the correct information. And then the other lady I just wanted to highlight, I got very close to during her pregnancy, and she was on 3 anti-seizure medicines during her pregnancy, and this is her beautiful baby girl. So I will conclude there. Thank you. I'll stop sharing, hopefully. And if anybody has any questions, I think we'll probably wait till the end. And thank you.